and welcome to this Waterloo Smarter Health Seminar. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us today for this seminar in the series entitled The Many Facets and Faces of Health Informatics. I'd like to welcome as well our web viewers and the Ontario Telehealth Medicine Network sites. This seminar is being recorded and is being broadcast over the web. As such, we ask that you hold your questions to after the seminar presentation so that we can get a real or virtual mic to you. A very warm welcome to our guest speaker, Dr. Mark Hackey from Wayne State University. Dominic will introduce Mark in just a moment. We're very pleased that the Lawson Health Research Institute has joined us to co-host these seminars. I'd also like to acknowledge our seminar sponsors, series sponsors, Borden Ladner Gervais, McKesson, Healthcare Information Management and Communications Canada. We could not host these seminars without them, and we're very grateful for their support. It seems like just yesterday that we're in this room to listen to Dr. Danny Sands talk about the illness in the age of E. I hope you all enjoyed the summer and feel refreshed, and that these seminars will continue to invigorate us over the next few months. Our next seminar in this series will be on Wednesday, October 29th, and we're very honored that Dr. Steed will be our guest speaker. Dr. Steed is the Associate Vice Chancellor for Strategy and Transformation at Vanderbilt University, and he'll be speaking on system-supported clinical practice. As many of you know, this seminar series looks at the many different facets of health informatics and some of the key people involved in these areas. So we've had people talk about personalized medicine and health informatics as a critical support to different areas in healthcare. We look forward to this talk, which will focus on MR imaging. Our agenda today is as follows. Dominic Covey, the founding director of the Waterloo Institute for Health Informatics Research, will introduce our speaker. Mark will speak for about 50 minutes, and then this will be followed by a facilitated discussion. So please keep your questions. We want to hear each and every one of them. Just signal to either Dominic or myself that you have a question, and we'll get a mic to you. All we ask that when you do get the mic is that you hold it fairly close so that it actually gets recorded on the video recording. We welcome questions as well from our web and teleconference viewers, so please send them along. So without any further ado, may I introduce to you now Dominic Covey, who will introduce our speaker.
Well, good afternoon and welcome. I'm very pleased to see you here. I just wanted to mention before I talk about Mark that Bill Stead, when he comes here, is one worth hearing both by you and your students. Bill has created the Center at Vanderbilt University, which is recognized as probably the most comprehensive and far-reaching institution in terms of health informatics in the world. Bill himself has just received major awards, and we are incredibly pleased to have him coming here in next month. So think about that as a possibility. The reason Mark Hackey is here is that we heard him talk a few months ago. Back in June, we had a meeting at McMaster University, and there was this strange guy there sitting quietly, but everything he said made sense. Now, if you've been at meetings, you know that most of what you hear doesn't make sense or doesn't matter, but he was articulate, he had a lot of thoughts, and we've been talking with McMaster about forming a joint institute of medical imaging, and the things that Mark said indicated that we really could learn a lot from him and a real opportunity in working with him. Mark is split between McMaster University and Detroit. He tells me that he spends 4 days a week in Detroit. So he's back and forth along this track a lot of times, and maybe a lot of opportunities to capture him. Already today, when we met with several people, I think he's already got his next few months of meetings ironed out with people at the University of Waterloo. So Mark is an opportunity for faculty and students at the University of Waterloo that just needs to be made into a reality. Interestingly, Mark's background, he's a graduate in theoretical high-energy physics. So I guess this proves that physicists can do almost anything, or better to have a job than none, or something like that. Now that the collider has gotten into trouble, and you probably noticed that, it got a helium leak, and they're going to be shut down until spring. So the Large Hadron Collider at CERN is right now in a mess after a big announcement. So we're glad you're in this field instead of that. Right now he's the director of the imaging program in the School of Biomedical Engineering and the director of the MRI Institute for Biomedical Research, and finally the director of the MR Research Facility at Wayne State University. He's a professor of radiology and biomedical engineering at Wayne State and an adjunct professor in electrical and computer engineering at McMaster University. Probably one of the most interesting things about Mark recently is that he was awarded a gold medal of the International Society for Magnetic Resonance Imaging in 2004. And he has a very great interest and an incredible track record in producing highly qualified professionals. So, Mark, we're looking forward to your talk. Welcome.
Thank you. Thank you very much, Dominic and Shirley, for the invitation. It's always nice to get back in my home territory here, since I graduated from University of Toronto and lived in Toronto for much of the first half of my life. I'm kind of excited today to talk to you about magnetic resonance imaging, and particularly brain applications. And because this is more health technology oriented, I have the second part of the title, A Global Approach to Studying Disease. And I want to close the presentation by telling you a little bit about how I think we can change the approach of medical research and make things much faster today because of informatics. Of course, a lot of the things I'll show you here comes about because of a collaboration with many people, including students and other faculty, such as physicians, including radiologists, neurosurgeons, and people from many other medical disciplines. We've enjoyed this concept of taking basic research into clinical translational research, and it's been a lot of fun in doing so. I do want to mention that this field of MRI has been rapidly developing, although it's hard to believe it's really more than 25 years old already. This is an old slide congratulating Paul Lauterbur and Peter Mansfield, both of whom I know fairly well. And it was nice that these gentlemen didn't have to wait till they were 90 to get the Nobel Prize. They received it while they were still reasonably active in their careers, although close to retirement. The other thing I wanted to point out is that very recently, imaging, the concept of imaging in general, has been considered one of the 10 top most important things developed in the last 1,000 years. And I think this is true. I think we're going to find out that from digital imaging in cameras that you use to the digital imaging that we use in radiology today is going to make the 21st century one of the imaging century. So I'm going to give you today a brief review of how MRI works. And if you never took the physics of that, I'll try to give you a 2-minute summary of how it works so you won't be so surprised the next time someone in your family has an MRI. You'll be able to say, I know how that works. An introduction to some new concepts, one that we call SWI, some examples of brain functional imaging, some specific clinical examples of neurovascular disease and neurodegenerative disease, and then we'll switch a little bit into imaging atherosclerosis and vessel wall, and then end up with this nice project, which is a neurovascular imaging center of excellence, where we'd like to collect a worldwide database of these types of images for specific diseases, which can then be data mined. And what better place than Waterloo University in the computer science department here than to tackle a project like that. So MRI is a method that really depends on the amount of water in our body. And when I give you this demonstration shortly, I'd like to say that MRI listens to the music that your body plays. And hopefully that plays a symphony and there's nothing wrong with you, but if there's any discordance in that, sometimes we'll find out that there may be problems there. MR is very sensitive to the soft tissue in our body because it's mostly water, it's 80% water, and that's what we're sensitive to in MRI. We tend to use very large and high field magnets that you can crawl inside of, and we prefer it if you don't crawl outside of them while we're taking your picture. And one can compare this system to a giant speaker. It actually works in a very similar way to that. And this is, again, the analogy that I make towards the music connection with MRI. So in MRI, we have to crawl into a fairly high magnetic field. Today we use 1.5 Tesla or 3 Tesla, for example. And you can see pictured in the upper right here a mother with a child. It's all right to go into this area as long as you're not wearing anything that's magnetic. So we usually do what we call the MR dance before we go in there. So if you do happen to do that, and you're a lady, for example, no bobby pins, no mascara, things like that. If you're a man, you're going to check that you have no keys in your back pocket, nothing in your front pocket. You don't want any of this metal being pulled out, because if that happens, it's going to go at somewhere around 100 kilometers an hour when it hits the center of the magnet. So that would be very dangerous. But don't worry if you have silver fillings, it's okay. I still get scanned, and I have survived that. Even titanium implants, for example, are safe if you're getting an MR scan. These magnets consist of a lot of niobium wire that's supercooled, and once this is brought to the appropriate temperature and the current is driven in it to create the magnetic field, then it basically sustains itself in a very consistent fashion over time. So I'm going to give you a very brief lecture in 2 slides here. I'd like to teach you a little bit about what MR is all about. If you put a water molecule inside a magnetic field, the protons that make up that water molecule are actually going to spin or precess just like a top about that magnetic field. And it's this property of spinning that we end up taking advantage of. The rate of that spin, called the precession frequency, is a constant times the main magnetic field. So I promise you nothing more complicated than a simple A equals B times C equation. Pretty much everybody can get this. The phase associated with this represents the distance, the angular distance that spin precesses around the main magnetic field, and it's nothing more complicated than the angular velocity times the time. Just like the distance you walk, if you're moving at a speed v is just v times t, the phase is just omega times t. So we see that, in fact, at the end, the phase is just this constant gamma, called the gyromagnetic ratio, which is 42.6 megahertz per Tesla for protons. And then times b and times the time represents how far this phase moves. And this value, 42.6 megahertz per Tesla, means that if we are at 2 Tesla field strength, for example, you're about 85.2 megahertz, you're just dialing yourself into the FM range, and that's the type of frequencies that we're looking at. The other thing to remember is that this spin we're looking at is actually a quantum mechanical property. So when I show you these MR images, you're actually looking at a quantum field result. These are things that are manifest because of a quantum mechanical effect. There's not too many things that we can actually look at today that represent quantum mechanics. Now, the question is, how do we get images? Because if you get into that magnet, all the protons in your body are merrily spinning around the magnetic field like this. Well, that doesn't help me. I can't really measure the signal when that's the case. So actually, it turns out that I have to twist those spins and tilt them down so that they're in a plane perpendicular to the original location where they were. And then they continue to run around the main magnetic field like this. That precession in the transverse plane allows me to actually pick up a signal by using a radio frequency coil. And I can distinguish different parts of the signal in your body. And I'm going to use your eyes as an example here. So let's assume your nose sits in the middle, and I can change the magnetic field from the left side of your brain to the right side. And I'm going to make the magnetic field a little bit lower here. And remember that the frequency is just gamma times b. So if I make the field lower here, the spins on this side of your brain will spin a little bit slower. If I make the field a little bit higher here, the spins will go a little bit faster. So that means I have a whole bunch of different frequency components throughout your brain. And it turns out that by using Fourier transform theory, or by using some mathematical algorithm to put it in layman's terms, we can actually pull apart all those different frequency components, and lo and behold, we get an image at the end. And that's really the basic concept behind magnetic resonance imaging. So now you all know that. You can talk to anybody who's had a scan before and let them know what we really looked at. So here's an example of an image. It's a transverse cut through the brain, showing some very interesting contrast. The bright white here represents the CSF, or cerebral spinal fluid. We can also see a little brighter tissue at the edges here. This represents the gray matter, or parenchymal tissue. And then the darker signal here represents white matter. And so this type of contrast that lets us look at the different tissues in the brain also helps us understand, is there anything abnormal here? Well, this is an image of a normal brain, and this is an image of a person with multiple sclerosis. And although you're not experts yet in terms of radiological imaging, I think you can see that there looks like there's something abnormal here sitting in the white matter. These are called multiple sclerosis lesions and represent some effect of that disease. So the beauty of MR is that you can start picking up what's abnormal compared to what's normal. And this is, of course, extremely important in recognizing the presence of any disease so that you can then treat the disease. So the key in radiology is diagnosis. And then once you have the diagnosis, you can send them to the right place for treatment. Now, you can also do other types of images. That previous image was called a T2 weighted image. This is called a T1 weighted image, and here you see that where we had CSF before, it's all dark, so a different type of contrast mechanism. You can see that the white matter is in fact now white or bright, and you can see the gray matter is a little bit darker, but it's not zero. This is really gorgeous contrast. What we can do now in MR is take a three-dimensional image. This image has information every millimeter inside your brain. So we're actually looking at data sets here that are on the order of about 16 to 100 megabytes in size, depending on what our resolution is. And this is just one of the scans we do in MR. We can look at it from a sagittal perspective, and you'd be surprised how many people we can recognize from their nose profiles. You can see the coronal perspective, where we see the carotid arteries coming up into the brain here. Or you can see it from a transverse perspective. Once you have that data in 3 dimensions, you can view it, cut it, and slice it in any orientation you want. Now, I'm just going to jump back a little bit here because I like to give praise to Bloch and Purcell, because back in 1946, they are the first ones who really recognized this ability to take advantage of the spin behavior of the proton. And their papers are really so precocious. I usually tell my graduate students to go back and read them because we're still rediscovering today things that they had done 50 years ago in their papers. They understood the math and physics so well that it took a long time for the imaging people to really recognize the power of some of their discoveries. And although quantum physics was really the basis of how they discovered these concepts, the fact that you can relate this like a simple top precessing in the Earth's gravitational field meant that a lot of the physics was very classical in nature, and it turned out to be rather easy to use. So these people were extremely precocious, no surprise. They also won a Nobel Prize for their work. And there have been, I think so far, 5 Nobel Prizes won in MR, and I wouldn't be surprised to see more coming in the future. Now, I think just from the images you've seen, I hope you're beginning to get a feeling that every family photo album needs an MR picture. Wouldn't it be nice if something did happen to you in 5, 10, or 20 years from now, if you had a baseline MR scan, you would be able to say, this is what my brain looked like 20 years ago, and this is what I hope it's similar to today. If you have a baseline scan, that's actually a very important thing. Although today we don't do health scanning, I can imagine sometime in the next 10 years there'll be a big thrust in this direction where people get an MR scan every 5 years just to make sure you're okay. In MR, we can do not just anatomical images, which are the structural ones that I showed you, but we can do metabolic images. We can image things like NAA, choline, creatine, GABA, glutamate, glutamine, and a whole bunch of other things, actually in vivo today, not quite with the resolution I showed you. We can do functional images. We can watch things like the heartbeat. We can look at kinesiology. We can look at how the brain thinks. And I will give you a few examples of that in a while as well. So there's a lot of flexibility to MR. And today, MR has become so broad spread that in a way I kind of think of it as the mother of all imaging modalities at the moment, because we tend to compare ultrasound with MR, or CT with MR, or PET with MR. MR is really blossoming and still, I think, in a very developing stage. Well, here's another example where we can collect the transverse images. And this is a different type of image than I showed you before. This image is very sensitive to local changes in deoxyhemoglobin in the blood. So what we do here is we have somebody lie in the magnet, just relax. And that gives us the left-hand image here, B. And then we tell them, move the fingers of your right hand, like this. And when they do that, it changes the picture a little bit. Because when you do this, the blood flow to that part of your motor cortex increases. The amount of deoxyhemoglobin in your blood decreases. and then this effect goes away. So here we had a lot of signal loss. Here we didn't have very much. When I subtract these two pictures, I find out that this is the part of the brain in the motor cortex that was telling me to move the fingers of my right hand. Now, there's a lot more to it than just the motor cortex. There's other parts of the brain involved, such as the supplemental motor area, and the midbrain, for example. And you can, by doing 3D imaging, we can actually map out all those parts of the brain that were involved. Now, how do we do this? Well, sometimes we do an experiment like this. We have the person not move their fingers, then move their fingers, and not move the fingers, move the fingers, because we really want to be sure that we're seeing a statistically important effect. And this is just an example here where if you're at rest, and then you move your fingers at rest and move your fingers. And so you can see quite clearly that this is quite a viable experiment to do and has fairly good statistics associated with it. The other thing we can do is to superimpose those pictures showing us the activation back on these three-dimensional images. So here you can see the different parts of the brain where you can look at the motor cortex response depending on which hand that you're moving. So here you're moving the left hand, and here you're moving the right hand. And you can look at that in all three orientations. Now, that's pretty interesting just by itself, but that has become very important in neurosurgery, because there, often you may get a tumor pressing up right against your motor cortex. And if it's pushing too tightly against it, the surgeon might come in and actually cut part of your motor cortex. In that case, you might lose the ability to move your right arm or your right hand. So today, people do this fMRI type of experiment before they do the neurosurgery. And they use the 3D images from the MR to actually help guide them during the surgical process. So there's a lot of exciting things going on in this direction using MR. Now, of course, this business about watching what happens when I move my fingers, I can also have you talk using verbs, for example, or using adjectives, and I can see the different parts of your brain lighting up there. I can have you count numbers, and I'll see something different. I can look at people who speak French versus English versus Chinese and watch the different parts of the brain in their language areas change. So I do like to warn my students, be careful what you think about when you get in the magnet, because soon I'll be watching you. Now, the other interesting thing about the brain is it's very plastic. And as we learn more and more, that part of my brain can become much stronger. People who play the piano, for example, or people who are very good in sports, we find that the blood flow to those parts of the brain actually goes up. And in fact, although we haven't really demonstrated this clearly yet, I wouldn't be surprised if the cortical activity involved for people who are very good in a motor skill, for example, doesn't actually increase relative to a normal person. So really the next science fiction approach, which we're not too far away from, is that you will be able to link these imaging modalities. It's not just MR necessarily, but maybe EEG and some other methods, where you can actually use that interaction so that you can sit here and start thinking and talking to your computer. And there is a company in California today that's actually trying to use these EEG devices so that they can trigger off of certain keys of how you're thinking so that you can actually move the cursor or play a computer game. So as wild as that sounds, I wouldn't be surprised in your lifetimes if, in fact, it'll be a very common thing. You'll say, oh, I want to call somebody. Let me just put my headphone on, so to speak, and you think about what you want to do, and you're talking to people. And, of course, that would open up tremendous doors, because if you can now link into the computer world, now you've increased your own personal memory dramatically. You can access anything, even if you personally forgot it. There are all sorts of things you could do and imagine in terms of talking to other people and communicating in a much better way than we do today. So that's very exciting. Now, I want to shift back into some more clinical areas. And to do this, I want to tell you just a little bit here that when we look at MR images, we look at something called the spin density, or just the number of spins that are there and certain properties that they have. We rarely actually look at the fact that these spins have moved a certain distance relative to their neighbors. Remember the phase that I talked about. That phase is directly proportional to the change in magnetic field from this tissue to this tissue. And the amount of angle tells me how much different it is. So we've started to look at the phase information to do a number of different things. And I'm sorry, this slide is just slightly out of order here, but this is to show you that in the brain we can image not just the tissue, but also the blood vessels. So this is an example of imaging all of the arteries in the brain, extremely important for looking at all sorts of neurovascular diseases. The amazing thing is this quality image can be done in less than 10 minutes in the magnet. So non-invasive, very simple to find out if you have any stenosis or other problems on the vascular side. Just another example from a different view. And another example. In this case, I point this out because of the computer science here at Waterloo. We can actually go into these images and just pull out the blood vessels by doing some very specific adaptive vessel tracking. We can then view them in 3 dimensions by using some shading algorithms, so we can get some very nice perspectives of what these vessels look like. And that's very important when the radiologist wants to see if there's any narrowing of the blood vessels. And so this will become, I believe, using 3D and virtual reality will become the way to teach radiologists and other doctors what's happening and to even observe the radiology data. And another example, this is in the neck. You can see the carotid arteries here. Often we get stenosis in the carotid artery. To being able to visualize this is critical to your health and knowing that you don't have any problems. Now, by using that phase information I alluded to, we can also start looking at the veins, for example. So it turns out the arteries, they basically stay at 0 phase. And so we use other techniques to measure them. But the veins, because they have deoxyhemoglobin in them, and deoxyhemoglobin's a little bit paramagnetic, they create a change in the magnetic field. That little bit of angle is enough for me to create a picture that shows the veins as dark. Well, that's kind of nice because now you can look at the arteries as bright and the veins as dark, and you can see all of the internal structure here of the veins. This is the medial drainage system, and the veins in this part, they all drain centrally. This is the peripheral drainage system, and they all drain out peripherally into the sagittal sinus. So this ability is really just becoming available. This technology has only been around in clinical systems for the last 2 years, and it may be that it could be 5 or 10 years from now before you find all manufacturers using this technology. That's too bad. That's a problem for Dominic, is to figure out how do we get these new developments into the field so that you as consumers have access to this type of technology and don't have to wait 10 years. This is another example of the same technology, but in this case clinically. This particular person had a venous thrombosis, and that's very bad news. It means it stopped blood flow significantly to a major part of the brain, and so much so that the blood flow was so slow that almost all the oxygen got pulled out of the blood. Well, that's very bad. If the blood didn't flow at all, we'd all die in a few minutes because there'd be no oxygen to supply our brain tissue. Well, it wasn't quite that bad, but clearly getting severe. These vessels all turned very dark because they have so much deoxyhemoglobin that phase difference got very big, and the phase difference is related to how dark these are. And this person needed to be, in this case, treated right away. And after a thrombolytic treatment to get rid of that clot, the blood flow returned to normal, and I think you can see right here that now he looks like he has normal amounts of deoxyhemoglobin, and that person is now functioning properly. So we're very sensitive now to these local changes in blood flow in the brain. Here's another example where using a contrast agent you can see abnormal medullary veins in the white matter. Here is using that same technology looking at the changes in magnetic field without a contrast agent. Now today there's a lot of controversy about using contrast agents because roughly 1 in a million people may be affected if they have poor kidney function. And we don't tend to use these contrast agents anymore for people with poor kidney function. The probability of having something go wrong if you don't have a kidney problem is extremely small, and maybe 0. We just don't know the answer to that question yet. However, there's a big push to use techniques that don't use a contrast agent, and here is an example of that. So if we know we're looking at a venous disease, maybe we can avoid the use of a contrast agent. Now, this is pretty exciting. This is really pushing the limits of this technology to look at veins. This is data from a 7T system. These are very high magnetic field strengths. There's probably a few dozen in the world today. They're used for research. But what really blew me away here was this is an example of a radiographic image where a dye was injected into the vessels. And you can see the Peel vein here, which is about 500 microns in size. And then you can see these venules, which are the thickness of your hair, so 50 microns in size. And the very dark area are capillaries. They're only 5 microns, so a factor of 10 almost each level. And here you can see the peel vein very easily, and you can see the venules quite clearly here. And that you can see varying shades of dark, so we can't see the capillaries directly. But unbelievably, using a resolution that's only about 200 microns, we can see evidence for 50-micron objects. So this is a very exciting direction for us, because we believe that a lot of developmental diseases and a lot of diseases related to aging are microvascularly oriented. So for example, Alzheimer's disease might start off by these little vessels breaking down, by the vessel walls breaking down. And I'll come back to that and show you some results. Here's another image that actually shows you this phase particularly. So where we have dark, that means a lot of phase change or a lot of change in magnetic field. And it turns out that that's due to iron content in the tissue. And it's well known that the motor cortex has a little more iron in it than the other parts of the cortex. And we started to ask, could we use iron for other purposes? The amount of iron we're sensitive here is in the level of nanomolars of iron. So we began looking at other diseases like Parkinson's disease, for example, or Huntington's disease. To our surprise, as we used this technology to begin looking at multiple sclerosis and even tumors, we found more iron content in these diseases as well. So this is a whole new finding. Multiple sclerosis particularly, people only had a hint that there were changes in iron content. That is usually considered a demyelinating inflammatory disease. But now we think there's more going on here that may open the door to helping understand and treat MS better. So the ability to measure iron is the takeaway message from this image. And I want to show you another example. This is, again, a cut through the brain. This is with India ink injected through the midbrain. So here you have the red nucleus. Here you have the substantia nigra. Here you have the medial geniculate. And now if we look at this phase image, which represents iron content, you see the red nucleus, the substantia nigra, and you see the left part of the medial geniculate here, all representing an increase in iron content. And it's well known that the basal ganglia in our brain has much more iron content than other tissues. So, is this right? Are we really able to measure iron? Well, let me show you a multiple sclerosis example that I alluded to. This is, and you see this ovoid shape here? Normally, this would not be seen in an MR image. Sometimes it is as a bright signal, like on the T2 when we saw the image at the beginning of the talk. But now we're seeing that this lesion has iron in it. This is something called a Dawson finger, being studied for almost 100 years. People have not done cadaver brain studies yet to stain for iron. One more example for you to show you that you might recognize this picture, that you can see a lesion on the T2. You can see hints of lesion in these other methods, but now look at the phase image that shows you the dark ring and the dark center, showing you that in these developmental rings, there's an increase in iron content. Now, we don't know the source of that yet. It could be ferritin, it could be hemosiderin, it could even be coming from an angiogenic response in that part of the tissue. So again, how do I know that this iron content is real? So I'd like to show you on this slide a collaboration with Helen Nicol at the University of Saskatchewan in Saskatoon, where she's taken a cadaver brain and she's imaged it with a conventional type of MR image, and then imaged it with this SWI phase image. And then she's frozen the brain, cut the brain, and taken it down to Stanford and used synchrotron radiation X-ray fluorescence, or SR-XRF, as a means to measure the amount of iron. And if you measure the absorption of that radiation, you can pick out iron from all the other metals that are present in the brain. And this is an image from the XRF scanning to compare with what we're getting in MR. And I think you can see very nicely that there's a very strong correlation here. So this gives us a lot of confidence that we're really able to begin to almost look at the molecular imaging level in people, even without the use of contrast agents. For those of you who have some radiology background, this is an example of a CT scan here, and CT shows calcium very well. And on the normal MR image, you see a lot of black holes, and these basically you don't know if they represent bleeding or calcium. In the right-hand phase image, you can see all the little bright dots. Those bright dots represent calcium in the MR because they have the effect of decreasing the local magnetic field. If these had been microbleeds, they would all have been black holes instead of bright dots. So MR now is even offering a complement to CT to look at small amounts of calcium that are present. Okay, well, this is just to tell me I'm about 3/4 of the way through the talk. And also, this is a lovely painting. Rembrandt really was painting what went on in the day. We all had to use cadavers. We had to cut the body from the outside to look in. Today, I like the analogy. This is a group that worked with me in cardiovascular imaging many years ago, of how we can look at the body from the inside out by using magnetic resonance imaging. So it really is quite a change in the last 400 years. Now, we can take some of these angiographic images that I showed you and really show them in 3D. And unfortunately, this was supposed to be a movie, but it's not functioning here, so I apologize for that. This was also supposed to show you this red bolus of blood that we can now mimic in three dimensions to see how it travels along the vessels. And I think this probably will not work either, but it's quite nice. Mathematically, we can reproduce the fluid dynamics associated with this and actually show how the blood flows through all of these vessels, and that way even look at comparing these predictions with what we see in MR. Now, this is another example, again, showing you all the veins. And in this case, I want to teach you just a tiny little bit of venous anatomy. This is at top of the ventricles, and it's called the septal vein. And feeding into it are a whole bunch of medullary veins. So basically, they're coming down like this, draining the blood into the bigger vessel. And then what can happen, unfortunately, is if you have an accident and you get head trauma, if you fall off a motorbike, for example, and hit your head, it may be that as you strike these vessels, the vessels themselves actually may not tear. But at these unions, everywhere where the vessel comes into the other big vessel, they can break. And for the first time, so I haven't even shown this at a scientific meeting yet, for the first time I'm going to show you using MR that we can actually see the tearing of these small vessels in that same area that I just showed you. And we can actually see bleeding at many other small areas as well. So MR has become much more sensitive in studying head trauma. There are, in the States, and I'm not sure of the numbers in Canada, but 1.5 million people a year get head trauma. Half of these people, we can't tell what's wrong with them. And we're hoping that this type of technology is now going to open the door to looking at those other half, because these people walk away with cognitive deficits, motor deficits, and we don't know why they have a problem. So until you can diagnose it properly, it becomes more difficult to treat them. This is a particularly good example of linking the imaging directly into the outcomes of the patient. This particular patient was a 19-year-old who had been in a car accident. It turns out he had a lot of bleeding inside the globus pallidus and putamen. And I missed this, but a neurologist came in and said, this little circle here, he says, that's part of the hippocampus. And after reformatting this, we found that the lower centimeter of the hippocampus had bled in this 19-year-old. And the neurologist walked out of the office and said, well, that's really good for me to understand because this patient has short-term memory loss. So up to then, there was no way to really link what we saw from the patient or cognitively to what was happening in the brain. So that takes us back to the functional brain imaging concept again, and also understanding what goes wrong when you get into an accident. So this is a very important area of research. Now, coming back to the small vessels again, this is an example here where we have many, many small black holes in this image, but you can see it doesn't look like any of those venous images I showed you a minute ago. These small black holes represent bleeding in the arterioles. Those are the 50-micron tiny arteries that feed the capillaries. And this person has dementia. This person has cerebral amyloid angiopathy. And now we can begin to clearly see this. We're just finishing a paper on this where we've studied 75 elderly people with mild cognitive impairment. 16 of these people have gone on to become progressively demented, maybe Alzheimer's. And 6 out of those 16 show this type of effect. Not necessarily this bad. And I'll show you a case here. This is a person that was imaged 3 times. You can see on the left, we don't really have big evidence for these microbleeds. Here we begin to get some evidence, and in the 3rd year, we have lots of microbleeds. And if we plot what happened to this person as a function of time, we can see the number of microbleeds continues to increase. And right here at the end of the 3rd year, this person was now classified as an Alzheimer's. So the reason I say time to go sailing, if you image me and I have 8 microbleeds, I'm going to retire, go sailing around the world because I've got about 2 years left. Now, that may not be completely true because where these microbleeds take place can be more damaging. For example, the fellow I showed you had hundreds of these microbleeds was actually only mildly demented. He was still doing okay. If it doesn't bleed in the wrong place, you're okay. But if one of them strikes in the wrong place, you can get a conventional stroke or you can have other cognitive damage happen. Now, again, I'd like to prove to you that this is not just, well, what are we seeing? Here is an example of imaging a cadaver brain again, where we see two of these black holes. In this case, we call them microbleeds. And here is the stained cadaver brain showing the same two microbleeds. And just another example here, again, showing this type of internal structure very similar to that. So we now know that most of what I have told you is probably true. And I'm not just telling you this for fun. All right, I'd like to go on and look at some tumor examples here. But before we do that, I'm going to show you a normal case where we had a person breathe normal air. So we had the normal amount of deoxyhemoglobin. We see the veins very well. And then breathe oxygen. So now the brain responds a little bit and the blood flow increases a little bit. And we have a little bit less deoxyhemoglobin in our blood. And then if I breathe something called carbogen, which has got 5% carbon dioxide in it, then that causes the blood flow in your brain to increase by about 20 to 30%. And it increases so much, there's almost no deoxyhemoglobin left, and the effect goes away. Now, you might ask, why is this useful? Well, it's very important to know how active tumors are before you give them radiation treatment or chemotherapy. So what if we use that technology to take someone who has a tumor, get this image, this SWI image, and image the person twice, once with carbogen, once without, and then subtract the two pictures? We find out that those areas that change the most, where the effect goes away, are the highest active areas of the tumor. So now it's possible to start looking at local oxygenation effects in tissue, and this is extremely important. It's extremely important for stroke as well as tumor to know how much oxygen is there. Now here's another example of a tumor case where we have two different technologies, one called T1 imaging pre-contrast and post-contrast. And you see how beautifully shown the edge of the tumor is post-contrast. And this is the SWI image that is sensitive to these magnetic field changes. And you can see that boundary is shown beautifully even without a contrast agent. And we think this is the beginning of recognizing the presence of angiogenesis, where the tumor recruits new blood vessels and starts to grow faster and faster. In this case, a bad thing. We really want to be able to treat it. There are many drug companies out there today that use anti-angiogenic agents to try to kill the effect of producing these small recruitments of vessels and hopefully kill the tumor in the in the process of doing that. All right, I'm going to shift gears a little bit again and actually look at something that could affect all of us. Atherosclerosis is something important for us to be aware of, and just in general blood vessel function and cardiovascular function. So here I'm showing a picture of some people, a young person and an older person, who had got into the magnet. We scanned in a cross-section of their leg to look at the veins in the leg, and both these veins look pretty dark and pretty uniformly dark. And that's actually good. That means he has the same level of deoxyhemoglobin. In this person, it's almost the same. This looks pretty uniform. There's something a little bit funny here. And then we scan them 40 minutes later. The young person still looks the same, but the older person has this very strange, bright, intermediate, and dark signal change on the vein. It turns out that in your leg, the cardiovascular system starts saying, after you've been lying still for about 20 minutes, I don't need this part of the blood flow anymore, and it starts to shut it off. So for the first time, we may be getting a better physiological understanding of why we might get deep venous thrombosis when we sit on an airplane for hours or sit in a car not moving for hours. This blood settles. That means that the red blood cells are no longer mixed uniformly with the plasma, and they sink under the influence of gravity. Okay, bad news, because these are very viscous. If you have any inhomogeneities or irregularities in your vessel wall, they may settle there, and if you don't have enough anti-clotting agent, that may clot. And of course, if it clots off, it comes up to your lungs, and you get a pulmonary embolism. So this can be perhaps a new way to investigate this, something that we can do in minutes in the MR system to say, you're at risk for this, you're not at risk for this. So I've shown you a lot of clinical applications here. I want to ask this question: when is the right time to conduct a clinical trial for diagnostic imaging technology? And I think it's when you get to the point that you've validated that the technology works. We don't want to wait 10 years and 20 years to do that. So one of the things we're doing now is to try and work with major sites around the world with these developing technologies into something we call the NICE project, the Neurovascular Imaging Center of Excellence. And our goal here is to get sites who are doing multiple sclerosis or stroke or tumor studies who are willing to use one protocol, so it's done the same everywhere, and then take that data and create a very large database from it. So we're looking at not hundreds of cases, which has been usually the case up to now in most places. There are a few centers like in Amsterdam and Rotterdam called the Erasmus study that have done 1,000 or 2,000 studies. We're looking at collecting tens of thousands, hundreds of thousands of data sets. And the whole comment I made at the beginning about changing medical research is that if we have access to that data and we can data mine that information, we may be able to discover how these diseases work. I don't want to wait 20 or 30 years to find out how to cure multiple sclerosis if we can do it in 5 years. And the problem is the way we do it now is so isolated in different islands of research that we're not taking advantage of the technology that is there, and we need to do that. So some of the advantages in putting this project together is that obviously we look for possible cures, but we also look to get funding from the governments, from the pharmaceutical industry, and then turn this around and not just use it to do data mining, but now go to the pharmaceutical companies and say, look, we've got 100,000 MS people here. If you've got a drug that works, maybe you can use this data, and now we have a baseline for those people. So when they get scanned later, we know what these drugs really do. And the drug companies are very interested at the beginning in testing the efficacy of their drugs on rats and animals and making sure it's safe for you and I. But a lot of times they really don't follow these over many years. And in fact, that's what they should be doing. So if we all had health scans, even if they didn't want to do it, we would be doing it for them for sure. So the other thing that we've got is we have a group of researchers, and we have a fairly big team of research people, about 25. The budget for this group is about $1 million a year. Not a lot of hospitals in the US or Canada can really afford to do that. But can they afford to maybe support one person locally and work with that center? Yes, they can. So we're now extending our arms out into China. We have 3 major centers in China. And I'm going to show you a closing example of this, where in the matter of potentially a few weeks, I can do a year's worth of research in Canada or the United States. So bringing these people on board because they have 10 times the number of people can really accelerate our research. So I'm going to close with these last few slides. This is an example of a carotid artery study looking at atherosclerosis. And you can see here the vessel wall of the carotid artery. And what we need to look at here is what type of plaque is there? Is there bleeding in it? Could that bleeding break away? And if it can break away, we better go operate on you so we get rid of that plaque. The problem is, this is a gorgeous picture. And when they do this scan, they get one picture through the neck. So what we're trying to do is to take all this other technology that I showed you during the talk, where we do things in 3 dimensions, and we've started to look at complete 3-dimensional coverage of the area of interest. This happens to be a normal volunteer where we're looking at the vessels in the leg. So this is the knee, and we're looking at the upper part of the leg and the femoral artery and the femoral vein. Here you can see on this phase image the vessel wall clearly for the vein. This is a nice straight vessel wall, so this person probably wouldn't have problems with DVT, for example. He doesn't look like he has any abnormalities. And then we did a patient. This patient was first done on CT, found that they had calcification in the vessel wall. We then ran them on MR, so it took us about 8 minutes to acquire the whole region of interest with extremely high resolution on the order of 1/4 of a cubic millimeter, so lots of data for the image processors. And you can see here the waviness of the vessel wall. This fellow has rampant atherosclerosis. That, as time goes on, those walls, those areas will become narrower and narrower, and they will develop stenoses. Here on the phase image, we can see this little bright dot, which represents the presence of calcium. So very quickly, in a method that doesn't require ionizing radiation, and CT, whole body CT scans still give you a lot of radiation. I wouldn't want to be scanned every week with CT. It would be very dangerous. The probability of getting cancer from that would be very high. Here, we can scan you every day if you want. There's no problems associated with it. There's no radiation in the conventional sense. Yes, there is radio waves. Remember, we listen to the music your body creates, but these are completely harmless to you. So, in conclusion, we have the potential, I believe, of making some medical breakthroughs here in imaging, and particularly magnetic resonance imaging. And my hope is that we can take radiology away from being just a diagnostic methodology, a diagnostic discipline, to one where we study the etiology of the disease itself and hopefully come up with some cures in the future. Thank you very much.
Wow, and very, very interesting. This is a time we have to give you a chance to make comments or ask questions. We have quite a bit of MR-related research that goes on at the University of Waterloo, so I'll give you a minute or two, and maybe you can put your hands up. We'll bring you a microphone, and you can ask the questions or make the comments into the microphone. I wanted you to take a minute about that radiation exposure issue, because I don't think most people are aware that MR imaging does not involve ionizing radiation, and I believe that there is no evidence of any type of biological impact from this. Can you talk about that at all?
Well, that's a fair question. There are two problems associated with this. They did some early experiments on rats where they put a clip on a blood vessel in a rat and put these rats in the magnet, and they all died. The reason was those clips, this was 25 years ago, those clips were made of ferromagnetic material. So, of course, you put it in the magnet, it bent, and it broke the blood vessel. Today, all industries that I'm aware of, all neurosurgical procedures, all cardiac procedures, they all, for the most part, use non-magnetic materials that are safe for an MR scanner, because MRs have become ubiquitous. They're everywhere. So that's an important thing to be aware of. If you do have shrapnel or something like that, that would be very dangerous. And so you do need to be careful if you had any metal in your body that it's non-magnetic. The other problem can be that we use radio waves. Now, generally, these are harmless. But if you put enough radio waves into an object, and let's say the frequency gets high enough, you're starting to get like a microwave. And, of course, we don't want to cook people. So, as you can imagine, there are all sorts of rules and regulations that when these manufacturers make these sequences, that they have to fall at the level of 10 times less than what the expected effect would be. There are occasions where people have got out of a cardiac scan where it's very intensive and they're sweating. And that's kind of the worst effect we've had. There is another case in the early days where they didn't wind the wires well enough so that these wires acted like an antenna and it burned somebody's skin. But today all those things are properly designed, so the potential of you having a problem in the magnet is extremely small.
Questions, comments? Anyone brave in the group here? How many of you are doing anything related to MR in your work? Could you put your hands up? Quite a few.
Well, you should definitely have some questions. Or I can give you questions to take home for homework.
Ed, I know it quite well. So Ed, you've done a lot of work related to MR, and you want to comment at all? Or? No? Okay. Here you go.
I'm just curious if you can give us some detail about the technique, the phase detection of the angle, the phase detection of the microstructure.
Sure. In this case, that's wonderful because then I can really give a problem because there may be some students in the audience here. One thing that you can show is that the phase behavior is completely independent of spin density, T1, T2, diffusion, and many other effects. So if you haven't done that calculation before, that's your homework for tonight. The interesting thing about phase is that as you change magnetic field strength, you can adjust the echo time that you're using so that the product of field times echo times remain constant, which means I can take this type of phase picture and generate the same phase image anywhere from 0.1 Tesla up to 11 Tesla, for example, on imaging humans. To do this, the problem with phase is that it's sensitive to all local magnetic field changes. And that means that we even have problems coming from the air tissue interfaces from your sinuses and the rest of the brain. So we have to get rid of those effects, and there are two ways to do that. One of them is to use a high-pass filter technique that gets rid of all low spatial frequency phase phenomena and just keeps the high spatial frequencies, which is what we're looking at when we look at the parenchyma, blood vessels, and things like that. The other is a full electromagnetic approach where you actually take the shape of the object and you predict the magnetic fields from the shape of the object. And in that case, you can actually predict all of these bad phase effects that come from the geometry, and you can pull them out. And then you're left with the pristine values coming from iron content, for example, or calcium content. Sorry, that's a technical answer.
Ed?
Okay, thank you. My name is Ed Verskey. I'm in the Applied Math Department, and Dominic knows me very well and knows that I can't stop talking. So I just first of all want to put a plug in and a thanks to you for your book. Mark is the author of the Big Green Book on magnetic resonance imaging, which we use. It's a wonderfully written book, and I just wanted to say thank you to that. We certainly know of your work. I have a student that's been working in super resolution, trying to increase the resolution of magnetic resonance imaging. And he actually came from Calgary, where it first started. He started doing that in his master's thesis, and he came to Waterloo. He said, Dr. Verskey, I want to learn a little bit more math to see whether we can do this. And the idea is, can you either by multiple acquisition, in other words, I mean, it's not practical. You take a patient and you move them a little bit, and you have two images, and can you get better resolution? Or can you play some tricks in the Fourier domain? So maybe just my question is, and I mean this to be sort of rather non-technical, is it really worthwhile to explore this? What my student is fine. He's going to defend his thesis in a month's time. We were actually going to ask you, but we knew how busy you were. So Terry Peters from Robarts is going to be the external examiner, and he found that actually it's rather difficult, given the noise in the images, that it's kind of hard. There is extra information. And I guess what I'm wondering is it really worth it with the technology improving the way it is and getting the resolution down finer and finer? Is it really worth exploring that?
Good question. I will try to address each element of the questions. First, I will tell you that it's an ill-posed problem by moving somebody and trying to do higher resolution. It doesn't work. Now, the next question is, can you do super resolution? I guess I would direct you to our 1988 paper on super resolution it's only a one-dimensional approach, but it uses Prony's method to do this. And it took us 15 minutes an image back then. I think it would take probably 1 second an image today to do that. And there you can really do super resolution. And that is worth it. And right now we're pushing the technology to be able to image in one direction to study the brain, to look at more changes in neuronal activity by getting down to the level of 25 to 50 microns on a conventional human scanner, just using the MR technology by itself. If I could take that old technology that we had worked on at that point in time and run it, I might be able to image, my heavens, it's a little mind-boggling, but possibly at the cellular level if I had enough signal to noise. To answer your question, really, we've never seen the vessel wall in the brain of any of these beautiful vascular data that I showed you. We're only getting to the point where I can look at the 100-micron vessels today. The vessel wall is about 10 times thinner than the diameter of the vessel, which means you're now looking at between 10 microns and 100 microns maybe for the smaller vessels. So if you can image vessel wall and see the beginning of the breakdown, maybe you can actually see what's happening in Alzheimer's disease. And there are other vascular diseases where the vessel wall breaks down. So being able to image even in one dimension with super resolution would be extremely important.
Great, thank you. That's a worthwhile comment right there.
Other questions? I have one. It's sort of, we had a chance to talk last night and had a very enjoyable time. I've read some articles recently. I mentioned to you about the ability to detect lying. And there have been several kinds of experiments that have been done. For example, if you've committed a crime and then you're confronted with it, there's a recognition in your brain, preconsciously, of the events of the thing. And they've actually tested that out. There are other ways, and they're using functional MRI to do this. Theoretically, I should bring out, recently, last week, it was in an article I read that the first conviction of a person using this as a lie detector has been secured in the United States, really worrying people who are the scientists in the area, perhaps like yourself. We have the potential now of beginning to confront people at the level not of their honesty, but of how their brain functions with regard to honesty. And it's obviously got some ethical issues there. What's the practicality of this on a theoretical basis? Is it really something that might work? I mean, from your experience with the fMRI, might it be something that can be trusted well enough in a court of law? Can you comment on that?
Yeah, that's a much tougher one. I can take the devil's advocate approach to that. If you called me up as an expert witness to argue against somebody saying that, there are many reasons why you might not believe it. For one thing, it's extremely inconsistent from shot to shot when you do it, even on the same individual. It's very inconsistent. If we all got in the magnet and did the same experiment, we find out that we would all get different responses, even for just touching our fingers, where we absolutely know where we should see this effect. If you have certain memories, specific memories that you're trying to pull out, rather than a more global repeat of what's an animal versus what's an inanimate object, for example, where you have to do a lot of scanning in this procedure just to make sure you found the area of activation, let alone having proven that what you're really seeing is an animal activation versus an inanimate object, or a noun versus a verb. I think we're still extremely early in these studies. I mean, you might all smile a little bit, but if you saw Jim Carrey in The Eternal Sunshine of the Spotless Brain, or something like Spotless Mind. Yes, thank you for helping my hippocampus on that one. Then that used MR, and in that movie they were using MR to find these memories. It's kind of cute. It might happen one day, but I think we're still a little ways away from validating specific memories and that type of paradigm. So I would be very careful to try to convict somebody on something like that.
So I expect their lawyers will be contacting you momentarily to this poor fellow.
So if my phone rings, I'll know why. Okay.
Yeah. Now, there was a cluster back here of people who said, you had your hands up, you're involved in some use of MRI. Would you be willing, one of you be willing to volunteer and tell us what you're doing? You look like a victim right there. She smiled just the right way to be a victim.
We're the MR team from Grand River Hospital.
Oh, that's it. Invaders.
Yes.
So, welcome. Glad you're here. Any questions you have or comments you have relative to the work you do in the, for example, it seems to me that one of the big issues is this international protocol work that you're doing. The images that you get are entirely dependent on the way the study is done, the way the machines are set up. And that seems like an important issue, to be able to do a study that's pretty well guaranteed to provide you with the ability to recognize a lesion or dementia or whatever it might be. How do you guys deal with that now in terms of the protocols that you use for setting up your instrumentation? If somebody else in the team would rather answer, I don't mind. They're all letting you hang.
Are you in the radiology
team.
Department then?
Yes.
Are you radiologists or MR technologists?
We are MR technologists.
Technologists. So,
yes.
So you have to run certain protocols when you do this.
If we're running a protocol, set out an international standard, they send it with the patient, and we just literally copy it over.
So you're using, and where do those come from?
Wherever it originates from, they send us that data, and we just use it. So wherever it is from, that's what we use.
But you usually, in fact, most hospitals actually design, amazingly, their own neuro protocols. So the difference in what I'm trying to do here, if you went to the local neuroradiologist and he goes, well, this is my magnet, and I kind of think it should be this way, and I'm going to change this parameter a little bit because I like it, and that gives me a little more authority and control. That goes on everywhere. The ability to step back and say, let's run one neuroimaging protocol for stroke or for multiple sclerosis. For example, can you do all the things I showed you here? You can do MRA, right?
We can do MRI. We can't do SWI.
You can't do SWI yet. What manufacturer do you have?
Philips.
So you have Philips. So your radiologist will set all of those protocols. And they don't even make them the same from scanner to scanner, even if it's the identical scanner, because the neuroradiologist sets the protocol.
Radiologist to radiologist. That's
correct. That's absolutely right. So there are some elements of this that I would like to see become base protocols, and they are for the most part. T1, T2, spin density, those are pretty common. But they're not all run with the same imaging parameters, and they're not all run with the same field of view, because people play with them. The day to play with them is over. We should be really having a baseline that we can use for medical imaging databases. And then after that, if you have something new, then play with it.
Now, right now, the protocol uses based on international protocols.
If we're participating in a particular study, then they send us that information. If we're doing our own clinical patients, we have our own set protocols.
Oh, okay, so that's the variation. And you'd like to have it constant for all of the above, really?
The basic conventional protocols should really be established on a constant basis.
I think your argument is, in order to get a quality image and to be able to recognize this stuff, you have to. In other words, it isn't able to be a personal preference as to how you set up the instrumentation. Is that fair?
Yes and no. Most of these protocols, with the right mathematics, if somebody takes a different field of view, I can rescale it, but I won't really have the same resolution. Those are small things if you're only varying the field of view by 10 or 20%. But in that case, you might as well have a fixed protocol anyways. So there are arguments to do that. It just makes it a little bit better to access. If I were to write a grant and take 3 different hospitals, say, to work with, and they all ran a slightly different protocol, and I applied for a grant for that, they wouldn't give it to me because the reviewers would say data wasn't collected the same way. And in that case, you can see a very, very strong argument for making sure we do things consistently. So the other thing is you must have the same problem. You want some new technology, whether it's DTI or something else, you have to go back to the manufacturer, or maybe you have to pay for something to get something new. You may not be uniform across Canada because you don't have the same access.
So, Mark, you were explaining how you took a MRI sample from, or your colleague in Saskatoon, and then verified using a different technology in Stanford. How important is it to use a different method to gain a level of confidence in the MRI data to separate out what is signal from what could be artifact or something like that?
I think it's very important. One thing when we look at tumors, for example, I saw an interesting talk in Montreal a few days ago for the MS Society, and also another talk just a few days later in Ottawa at a convention run by Siemens, where a neurosurgeon, in this case, showed cutting open the brain. And he says, in the MR image, it was absolutely clear what you were looking at. And he said, in the real brain, I couldn't differentiate it at all. So the only way to really differentiate that was not a visual sight anymore. Now MR has become more powerful than the neurosurgeon's eye. They have to go and do the biopsies, right? Or they have to go and do the histopathological studies afterwards and validate, why did we see this change? Does this brightness correspond to increased choline levels, for example? Does it correspond to increased water content? Do the black areas we saw in SWI represent tons of microbleeds or an increased capillary density? We're still so new at some of this. We need to do this type of validation all the way down to the level of the chemistry, such as N-acetyl aspartate, for example. All of these things should be validated.
Interesting. Jeff Orchard in the School of Computer Science here did his, I think it was his PhD research related to MRI, and was able to demonstrate the production of an artifact. And you may know this better than I can you? Anyway, he was able to show the demonstration of an artifact based on the order of application, as I recall it, of the various transforms that generated in pictures an artifact in the brain consistently. And if you reverse the order or change the order, the artifact disappeared. I don't know if you've ever seen anything of that, but it does seem that the mathematics that are involved could generate artifacts under certain conditions. And how do you, I guess, deal with that? How do you know when a region lights up here, a region lights up there, that in fact one of those is not an artifact?
Well, that's a very good technical question for the scientists and for the MR technologists. I can tell you something called the Syrinx artifact that you may know from a long time ago. And it's very simply related to an artifact of the Fourier transform called Gibbs ringing. So if you have too low a resolution, at the edge of a step function, you get a very little bright peak of about 9%. And if you bring two objects fairly close together that both have edges, like the edge of the spinal cord, for example, these two peaks will get bright, and then they'll get dark, and they'll add coherently. And you can end up seeing dark lines in the cord and a bright line right in the middle of the cord where they add back up coherently again. And that can be considered a Syrinx defect in the cord. And in fact, it's not. So how can you validate this? Well, clinically, you can go in and increase your resolution by a factor of 2 so that that artifact, if it's truly an artifact, will pull away from itself and start to disappear. And in that case, you know that it was an artifact. Mathematically, we would simulate this situation. We would actually create that data and then operate on it with our different algorithms and validate whether or not we could do conventional Fourier imaging, or if super resolution has no Gibbs ringing artifacts, for example, you can then validate this type of thing by simulating the data.
Interesting. Comments? Make sure I don't miss anybody. Are there any physicists, by the way, from the physics department here? Just curious. We have a physics department, as I mentioned to you, that's done quite a bit with I can't remember the name of the high-resolution instrument, where they can look at a frog's leg, for example, and image it, as well as doing any kind of NMR studies, but there's nobody here to talk about that. I want to switch tracks for 1 second. You mentioned in your talk, and we've talked previously, about the concern of the time it takes from an invention, if you want, or an idea becoming available until it actually appears in an instrument, and then finally the people actually adopt it. Can you talk a bit about that, about what the problem is and what we can do about it?
Well, some of the technologies that we use today have been around 20 years. The problem is that the software for it must be approved from the government. So the systems go through these approval stages. In this case, the FDA has to approve it. Methods have been used sometimes for 10 or 20 years and never having made it into this approval stage. So a lot of the researchers like us, we've got to use the technology, and it never quite makes it to a push-button MR technologist approach. This is really unfortunate. They can still use it from a clinical point of view, by the way, but it can't be sold by the manufacturer. We definitely need some mechanisms out there for better communication, for better testing of these methodologies. And I hate to come back to the NICE concept, but that's part of the reason behind that. If you have enough integrated sites working together, we can get 1,000 cases in a year instead of 1,000 cases in 20 years. And in that way, we'll be able to know very quickly whether or not that technology is worth pursuing, and then you'll get the companies behind you.
Interesting. Any final comments or questions? I do have, sorry.
So I'm just wondering, in terms of technology improvements nowadays, is it more in terms of hardware improvements for the scanners or pulse sequence improvements, or is it a data processing type of improvement? So like generally, like what are the trends in the present day for MR technology improvements?
Well, I'll be biased here. If I were a student today, I'd be very happy to come to Waterloo. And that's basically because of the math and computer science. The extent of the hardware developments in terms of gradients and RF coils has come a long way. There probably are limited for a number of reasons in what the next level of improvement will be because of safety reasons, and probably because of just some simple physics reasons. And that, of course, leaves the door open to all sorts of new processing techniques. So the next level that has happened already is a great marriage between hardware and software, trying to use the new hardware in new sequence development and new software development. So those three together create the most powerful paradigm for you to work with. And so there's going to be a lot of computer science involved in that. And also to do the data mining here, to go back through that data and extract everything from volumes to automatically recognizing the presence of tumors, evaluating blood vessels, it's all software oriented. So if you gave me 100 students, I could keep them all busy without any problems.
You're approximating that, I guess. And by the way, there was one slide where you show a research group, and I presume the fuzzy-faced guy was you in there?
Yes, there's a little metamorphosis that's gone on since then.
I was just wondering what happened, why the change, you see. Anyway, thank you very much. Really appreciate your talk.
Well, I'd like to thank Mark as well. I think we've learned a new type of music today, at least I did, and so thank you for a very interesting seminar. Here's a small token of our appreciation. And thank you all for coming today. I really appreciated a very good audience, full of questions, and I hope you'll come back and see us next month.